Today my topic is going to be on approach to solitary pulmonary nodule, and likewise I will start with the definition of solitary pulmonary nodule. As we all know, it is a single discrete opacity and it should be less than or equal to 3 centimeter in size, and anything above 3 centimeter we call it as a mass lesion. And in this 3 centimeter, if it is a solitary pulmonary nodule, the surrounding parenchyma should be normal without any hilar nodes or mediastinal nodes, and it should not be associated with any atelectasis or pleural effusion. Only a plain nodule of less than 3 centimeter, it is called as a solitary pulmonary nodule. Anything more than 3 centimeter, it is called as a mass, and anything less than 8 millimeter in a CT, it is called as a subcentimetric nodule. And incidence and prevalence of SPN. SPN is found in 1 to 2% of all chest X-rays and clinically silent in 90% incidental finding most of the time, and it occurs at any age and there is no sex discrimination is not there. Mostly it can be equal on both sexes, and younger age usually it is considered as a it is less malignant than other conditions. And the risk factors are, if the patient age is more than 5th or 6th decade, there is a high chance of becoming malignancy, and history of smoking index of more than 300 or 400, or average smoker having a 10-fold risk, and a heavy smoker has a 20-fold risk in the development of lung cancer when compared to a non-smoker. And the nodule size is likely to be of malignancy if it is more than 3 centimeter, and it is prior history of malignancy is there is a high risk factor, and if there is a travel history, you have to think of a benign lesion also. I will come to that in the later part of my talk. And occupational factors like asbestosis, radon and nickel exposure, and if you have an SPN, you have to think of a high possibility of a malignant lesion. And coming to the differential diagnosis of solitary pulmonary nodule, it may be a malignant tumor or it may be a benign tumor. If it is a malignant tumor, first comes a bronchogenic carcinoma. In bronchogenic carcinoma, it may be most common is an adenocarcinoma, or it may be a large cell or a squamous cell or a small cell carcinoma. Carcinoids can also present like a solitary pulmonary nodule. Pulmonary lymphomas, pulmonary sarcomas and plasmacytomas can also present as a solitary pulmonary nodule. And solitary metastasis is also more common in secondaries from the colon, breast, kidney, head and neck, most commonly from thyroid, germ cell and sarcoma and melanomas can present with the secondaries, and solitary metastasis from the primary lesion from colon. And coming to the differential diagnosis of a benign tumor, it may be a hematoma, or it may be a benign adenoma, it may be a lipoma. In conditions with infectious granulomas, most common in India is tuberculosis. In Western world, you can have a histoplasmosis, coccidomycosis, ascariasis, echinococcus coccal cyst can also present like an SPN, and non-infectious granulomas like rheumatoid nodules can present like an SPN. Vaginous granulomatosis can also present, and sarcoidosis sometimes can present like an SPN. And the other benign causes of solitary pulmonary nodule or bronchiolitis obliterans, organizing pneumonia, silicosis, hematomas, pseudotumor, spherical pneumonias, pulmonary infarction, AV malformation and amyloidoma are most common or a very rare presentation of a solitary pulmonary nodule. I have discussed about what are the conditions that malignant differential diagnosis of malignancy that can present as a solitary pulmonary nodule, and I have discussed about the benign conditions where it can present as a solitary pulmonary nodule. Coming to the etiology, 40% of the SPN are malignant, and 80% of the benign lesion is in infectious granulomas, and 10% are hematomas, and 10% are non-infectious granulomas. As I told, it may be a rheumatoid nodule or it may be sometimes a sarcoid. And malignant conditions, 25% are metastatic from other places like colon, as I told, thyroid, or it may be from the melanoma that can present as a secondary metastatic solitary pulmonary nodule. 75% of the bronchogenic carcinoma and carcinoids can present like a SPN. What are the stimulants of SPN? As a solitary pulmonary nodule is a extrathoracic artifact. You should be more careful in delineating from the artifacts first. It may be a cutaneous masses, most commonly it may be a lipoma or neurofibroma, sometimes a nipple can also, shadows can also present like a solitary pulmonary nodule. Bony lesions like sclerotic lesions or a healed fracture can present like a solitary pulmonary nodule. Pleural tumors, pulmonary vessels, sometimes you can misguide as a SPN. So, you should be more careful before delineating whether it is a solitary pulmonary nodule or a stimulant or an imitant of a solitary pulmonary nodule. And what are the modalities used in diagnosing solitary pulmonary nodule is a chest X-ray. Most common chest X-ray usually in a PA view and sometimes in a lateral view you can pick up the lesions, and computer tomography can pick up whether it is a contrast or non-contrast CT, you can pick up the solitary pulmonary nodule. PET CTs you can find out the solitary pulmonary nodule, and FNAC and biopsy can be used for the diagnosis of solitary pulmonary nodule. The two issues is a lesion detection and lesion characterization, whether it is a benign and malignant. I will come to that, how to find out whether the higher chance of benign lesion or a higher chance of a malignant lesion in the later part of my talk. So, modalities used in the diagnosis is the most common is a chest X-ray. Most of the time it may be an incidental finding in a CT or an X-ray. And chest X-ray, as I told, it may be most of the time it may be an incidental finding, and it may be a pulmonary or extrapulmonary. You have to rule out that first. And if it is more than 8 to 10 millimeter nodule are identified by the chest radiographs, and a lateral chest radiography or a fluoroscopy most commonly used to help to find out the location of the nodule. But with the advent of CT and PET, we are not going in for a lateral view nowadays, but previously you can see here this nodule here close to the diaphragm on the right side, whereas here you can see here in the posteriorly. It is predominantly the lesion is in the sixth segment, probably posterior or and the sixth segment or posterior basal segment of the lower lobe or a superior segment of the lower lobe, where you have the nodule here. So, this is the way always you have to compare with the previous X-ray, and the previous radiographs are more important. Sometimes you can see the size has increased. So, always you ask for a compare with the current radiograph with the previous radiograph and ask the patient to bring whenever they come for the clinic.